the interpretation, you have a button at the bottom of your screen, the very right corner on the bottom of your screen that says interpretation. If you click on that button, then you will be able to see the list of languages, French and Arabic. And if you'd like to listen to this webinar in French or Arabic, please press the relevant button. Now, for this very reason, what we need to do as the presenters, we will be speaking slower than we sometimes speak in normal life to be able, for our interpreters to catch as much as possible, because they're doing a tremendous job. They're catching what we are saying in English, and they're interpreting it in another language into another language at the same time. This is a difficult task, and we will try to be as compliant as possible. The next feature that will be useful is the chat function, and what we the questions and answers function. And I apologize for my screen to closing. This is the button at the bottom of your screen also. And when you press this button, what you can see is the Q&A, and you press this button, you see a field opening on your screen here. And this is where you type your question. And if you type your question here, we will be certain to respond to it, because it stays here until we respond to it either in writing or during the webinar. So please use this function to ask any questions that you have in the nature of the webinar. Now, another function is the chat function. Now, this is when you press this button at the bottom of your screen, it opens in a chat, and this is where you are welcome to introduce yourself, or let us know something that's interesting to know about you, or perhaps share your experience. This is where we will read and we will comment on what you see. Also, we have started our webinars as far as 2019, and we've had 27 so far. And to access the recordings of our webinars, you go to IFC Healthcare Webinars, you Google it, and then it takes you to this page over here that says IQ Healthcare Webinars and Training. And we have the recordings of all of our webinars here. Now, another page that's associated with this one is the IFC IQ Healthcare tool, where we provide you with information about what we do, the assessments that we make and how we make them, and also about some brain teasers and how-tos on healthcare quality issues. We also have a YouTube channel that you look for by typing IFC IQ Health. And here you also have the recordings of our most
Natasha, you're on mute. And we cannot hear you. I think I can continue from this moment. There is a channel on YouTube, and there is simultaneous streaming on YouTube, so you can find all the recordings if you missed certain webinar or you want to recap on a certain thing on our page for IFC IQ Health. Natasha, can you please stop sharing? So hello, everyone. Welcome to IFC series of webinars. It's great that you are still joining. And before I introduce our speakers today, who will be talking on such a challenging topic as what is the difference between the quality improvement plan and the quality improvement program, what are the features of the quality improvement plan and program, and how to design the one which will be successful. And also we will be discussing interesting examples from real life. But before we do that, I wanted to make an important announcement. As you know, as you might know, every 2 years, IFC carries out conferences, healthcare conferences, and this time, this event is coming soon, February 14th to 15th in Cape Town. And in this regard, we are carrying out a contest. And the subject of this contest is very interesting. So basically, many hospitals, when we start talking about quality, they start saying, oh, we think quality is very expensive. Or why should I invest in quality and what will be the payback? Or another question is, how is quality? And this is, by the way, the most common question that we are asked, we as quality specialists. What's the conversion of the quality into revenue? Okay, I pay to my newly appointed quality manager, I buy some new things which are required, I refurbish, I change processes, etc. What will be the revenue in this regard? Will I get more patients? So that is why we decided that we want to make cases, public cases of successful turnover from the investment into quality, how what impact it had on your revenue. So if you have cases when you implemented certain things in regard of quality, you made certain changes and it had impact on your business case, you're welcome to share your story. Now I wanted to show you the application form. That's all that we need from you. Fill in this application form and you will be a member of our contest. So we actually have a prize for the winner and for the runner-up. It will be a waiver of the fee to participate in the conference, but most importantly, you will get visibility. So if you have a story of success to tell, to share, then don't hide. Make it public, and all the hospitals around the world will know about you. And maybe many will want to learn from you. So this is, let me quickly go you through the application form. It's very easy to fill in, nothing to be afraid of. So we just need some general information about the facility, the size of the facility, and just a few things about the case. So background of the problem. So basically what the quality related issue gap was that you had to solve, what were the actions that you implemented, so what had to be done and what actually you had to invest in, the timeline, the amount of investment, and the measurable results. When we start talking about this, by the way, Maria will share a link also in the chat that you can use to access to the registration form and also information how to become a member of the contest. It is very important also to mention that once we talk about conversion of quality measures and quality related investments into revenue and into business case, very little information is found globally in the public resources. That's why we decided we need to change the situation, and you can be one of the pioneers presenting your case and letting everyone know that yes, quality means a lot and quality can change the revenue, quality can bring more patients and make the hospital more successful. So that's the information about the contest. And now let me introduce the first, actually the speakers today. Let's introduce today all the speakers, and briefly I will tell you what we are going to discuss today in specifics. So the first speaker will be Ajibike Oyewumi. I'm sure you already know Ajibike. She is IFC specialist in healthcare quality and patient safety. And Ajibike will be talking a little bit of theory and a little bit of practical tips on successful designing and implementation of quality improvement plan program, and also will tell you what the difference is and how to move from the level of strategic planning to the level of practical implementation. So the next speaker today will be Penina Kiria. from Avenue Hospitals, and Penina will tell you a real-life story about the journey towards quality improvement of one hospital, one specific case. And the third speaker today will be Jackie Stewart, CEO of Kasasa South Africa. I'm sure many of you also know Jackie very well. And Jackie will give an overview and a few inspiring examples how several hospitals made their quality program work and have effect in reality. So Ajibike, first speaker, the floor is yours.
Good morning, good afternoon, good evening, everyone, wherever you are. Good to see you again. I'm glad. Oh, wow. Okay. Sorry, I can hear the translator from my
French
end.
translation. Shikrazad, could you please go to French channel? We hear in English French translation.
Okay, so let's try again. Good to see everybody here, especially those who keep coming back. I'm always so glad to see, us all trying to learn more and more and more about quality improvement, because we don't have a choice. That's the way to go for many, many reasons that we will see. So today I've titled my talk, Get with the Program. Because what I am seeing from experience, and partly my experience and partly the experience of, other hospitals that I've visited, is that we tend to see quality in one aspect. I have been lucky to, I think I'm still growing my understanding, but understanding the depth and breadth of quality, which we have to practice holistically, to make quality sustainable. I worked in a hospital. We worked very hard and got quality accreditation. We got international accreditation. But I'm sure everybody there will be able to tell you that, once we got accreditation, shortly after, it was like everybody thought, let's get back to business as usual. We've attained the goal, so we can keep doing things the way, it was before. And that is the story I'm hearing around the world, where once an organization starts out with accreditation in mind, it's very difficult to sustain. And you're actually seeing literature around it. There's research saying what's going on. Why is it that when people get accreditation, once they get accreditation, then things begin to dip? And I'm sure Jackie will be able to tell us, as the head of an accreditation body, kind of things she sees. So how do we, what is it that we need to do to make quality, a plane where we keep going? It just becomes part of who we are as an organization and how we deliver care. And I'm sure there are many answers, but I'm going to talk to you about just one aspect of it today. The other thing I see is when organizations look at quality largely from the quality improvement angle. So there's been a lot of focus on quality improvement, especially in the developed world. And that's largely because they have established over time quite, a lot of basic things that are taken for granted, that are so basic in terms of quality that they begin to, what they're talking about now is improving. Of course, the term improvement means you already have something in place in terms of quality. Not just how you work, but you already have some things in place, and it is what you have in place that you can improve on. You can't improve on something you don't have. Okay, so, it's important to know that. So quality improvement, is systematically applying an approach to solve complex issues. And if you do quality improvement properly, the way it's meant to be done, you'll see that there's a thinking around quality improvement. That means that you have to think through what the problem is, be sure you identify what the problem is, and then begin to test different ideas till you get a solution. And that means quality improvement is about learning. Quality improvement would help to reduce unwanted variation in your already established practice. It helps to use it for reliably implementing new interventions and discovering new solutions. Okay, it involves quite a bit of reviewing of data. That means you have to be collecting your data. Okay, so in fact, in the last couple of days, we've been talking about quality improvement quite a bit. And we finished the second module yesterday. We had a previous module. And so in that time, we talked about a quality improvement plan, which is about what areas you want to improve and how you identify opportunities for improvement. You set up your quality improvement projects, find a methodology, the different tools that you can use, measuring to be able to understand and do your quality improvement. So I'm sure the one that, one of the methodologies that almost everybody knows is the PDCA, right? Plan, do, check, act. You identify a quality problem, you plan, you do it, you check whether, what results you've gotten, if you've been able to do what you're doing well, and then you act on that result. However, that quality improvement is only a part of your quality program. That's the thing that I want to talk about today, and hope that, people, you begin to think about it a bit more. It took me a bit of time to get it. I'm sure most people here are smarter than me, but it took me a bit of time to get it. And since then, I've become almost like an apostle trying to get people to understand that there are 4 aspects to quality improvement. There are 4 aspects to quality, and what I then call a quality program. There's quality control, there's quality improvement, and there's quality assurance. The objective of setting up a quality, which is like an umbrella for everything, is to implement a holistic system that is capable of managing the whole healthcare services to deliver the high quality care that you want to in a measurable and, I dare say, in a sustainable way. Okay, so your quality program really looks at how you improve your patients' and clients' outcomes, the experience. It looks at improving efficiencies, the effectiveness of everything you do becomes a part of that. All right, and then looking at performance at all levels. There are some universal principles of quality management that must undergird all you do when you're setting up a program. One is the customer focus. Quality is about the customer. Though you have different kinds of customers, internal customers and external customers. Internal customers, of course, will be us working in the healthcare, because whatever work I do and is an output is an input for somebody else. So they become my customer and I am their supplier. But you do have different kinds of customers. The patient is the center of it. Understanding the patient's needs and making that the core of the business. You have other customers, which would include your payers, your regulators, your community, and all the other people around it. Leadership is, it's something we will keep saying. Yeah.
May I interrupt you? We don't have, could you share slides, please?
Oh my God. I'm so sorry. You should have told me earlier. Okay, so you know what? I'm gonna go. Can you see my slides now?
Yes.
Not full mode.
Yeah, I'm going into full mode now. So this is where I started from. And I'm talking about, getting with the program. looking at the universe, not just the earth, right? I talked about quality improvement and the definitions of quality improvement. The work that we've done so far, looking at quality improvement plan, opportunities for improvement, PDCAs being the core in many areas of quality improvement, even though there are other methodologies. And now I'm talking about the quality program, holistically, a quality program that involves quality planning, quality control, quality improvement, and quality assurance. Shahrazad, I'm sorry I went through that very fast. Then the objectives of a quality. Now I'm talking about the principles of quality management system or a quality management program. At least in my head at the moment, a quality management system and a quality management program is essentially the same. So customer focus, most important. Leadership, we keep saying, it's become a mantra. Leaders cannot outsource quality. It is the function of leadership to drive quality. You have to involve the people in the program. So if leadership decides to sit in a boardroom and take all the decisions about quality and just push it out, then we're not forming a quality program. You have to involve the people at the front, the people who do the work. Okay? You have to take a process approach. You have to take a process approach and a systems approach, understanding that you work in a system and you want to provide quality for your system overall. So you can't focus on the clinical and you cannot focus only on the operational. You have to focus on the whole system because everyone affects the other. You have to be doing continual improvement, which is what quality improvement comes. Continually improving. All the data you're collecting and all that, you're continually improving. So it's okay to start at the bottom. Do not be afraid of those numbers. Do not, as a leader, knock your people over for bad numbers. More important that we see an improvement, a continual improvement in the numbers. You have to use data and reliable data. So if you are not collecting data to understand your system, both clinical and non-clinical, then you still are not running a program. And then you have to think about mutually beneficial relationships. It is not, so when we talk about your suppliers, not just your equipment suppliers, you have to think about the person who you're working with. So you have a customer focus, that is the person who is at the center, the clients, your patients and all that. But we also have to think about the staff. Think about your staff who are supplying the effort and all the thinking that goes into it. Okay, and your external suppliers as well. Okay, so like I said, there are 4 aspects to quality program, and I see it as a house. It's a house that has 4 main rooms. If you think about it, in your house, there are 4 functions that you need to have. 1, you need to have your living room that you sit in. You need to have your kitchen where you prepare food. You have to have a bedroom. You may have 6 bedrooms, you may have 1 bedroom, or you may even share your living and your dining room may have one. Your living room and your bedroom may be one area, but then you also have to have a bathroom. So those are the 4 main areas you have to have. If you remove any of this from a house, you are not likely to be very comfortable. If you don't have a place to have your bath and you're having to go outside to your friend or some place to have a bath, then it wouldn't be very comfortable for you. Same thing with quality. You have to have quality planning, which includes the design and implementation at the initial level. You need to have quality control, quality improvement, and quality assurance. Then there are some supportive elements that you must put in place. If you don't have a good foundation or good pillars within your house, the house will come down. any bit of shaking, any bit of an earthquake or some disturbance will bring that house down. So you think about the supportive elements as being leadership, the organization of quality, and I'm talking about like the quality structure. How have you organized quality within your institution? The culture of quality and safety, the training, making sure people have the knowledge, tools, and skills for quality. So in this kind of instance, I'm almost assuming that you have all the clinical knowledge and, operational knowledge you need to have, but you also need to have quality knowledge, and then you have to provide adequate resources. These are supportive elements that must be in place. Okay, so when you talk about quality planning, what's involved? You have to understand the needs of your population and your customers. And we're not just, you need to go beyond just the satisfaction surveys. Did we do well? Will you come back? But how do you find out what is required? How do you use your data to know what other services are needed and how those services are needed? You then go on and set standards for the output, as it were, whether they are accreditation standards, professional standards, taking on international clinical guidelines as standards, benchmarking yourself against what you expect as outputs for your customers. You need to put in place the optimal structure, like I'm talking about, managing quality, put in systems, that's where your policies and procedures that you write all come in, and put in an environment that allows you to deliver quality outcomes. You build in quality right from the beginning into that product. So it's not just enough to bring people, put them to work without thinking about how do we ensure that they're able to deliver quality products? How do we ensure that they have time and space to think through the work that they are doing? If you don't give them time to think, then you're helping them fail, because they need time to review, to reflect, to come together, all those things. The staff committees that are needed, your reporting lines, making sure everybody understands their roles and responsibilities. These have to be defined at the planning stage. And a lot of it is based on your lived evidence, on your lived experience, then the evidence and best practices. It is also at this stage that you're thinking about how do we make time every time. Okay, you minimize costs by planning in your efficiencies. Now, quality planning is often done once in a year where you sit down and think through it. Yes, so those strategy sections actually have a use, but you may need to do planning beyond that. You may need to come together to review, to plan again by department or by organization, or when you're bringing in a new service, you may need to do some planning, but you need to do it in a focused, directed manner. Then quality control. Quality control is actually about the people at the workplace reviewing, owning the quality of the work they do and reviewing and making things better. So you don't wait for an audit or, some kind of accreditation or visit even by the quality department. It is those hurdles that you have in the morning to quickly review your numbers. So how did we do last night? How did we do last week? What safety issues did we have? What are we going to do? Planning for the work, controlling the quality at that point. So having regular huddles, having things for visual management at the workplace. That is a very important part of quality. So if you haven't started putting up quality boards for your various units where they're tracking their numbers, many hospitals, quality department has the numbers. When you ask the department staff, so tell me, how are you doing with pain management? Are you managing your patients well? What percentage of your patients get their pain scored? They don't know, but quality knows. Quality has the data. No. We're saying all those things should be done by the team themselves. They need to know what they're doing and they need to be monitoring their performance real time. Then quality assurance. Quality assurance is an external thing. And when I talk about external, I'm not talking about just accreditation bodies. That's one of it, right? But that's not just it. Auditing, when you take time at intervals to look through the work and then provide feedback, that is quality assurance. So whether it's done by the quality team, whether it's done by an accreditation body, whether it's done by an inspection regulatory body, that is quality assurance. It has its place because it helps. It's very good, which is what we do, right? We give you we help you see yourselves from an external pair of eyes. And it's always good to have that. Okay, we help you to check where, how you're doing in relation to the standards that you have subscribed to. But never forget that it's a snapshot in time. It doesn't tell you everything about your hospital. It tells you what we see in 2 days, in 3 days, not what is actually going on all the time. So we do recognize that it's an essential part, but it's not enough. Okay, and it's not. Quality assurance doesn't really help you to achieve new levels of performance. You need to have quality improvement, quality control, especially for those. So, what am I saying? In essence, quality improvement by itself or accreditation, quality assurance by themselves do not represent a holistic approach to managing quality. There's a need to use quality improvement and quality planning together with quality assurance and quality control. The essence is knowing when and how to use all these in a balanced manner. So my challenge to you today is go back into your system, put those 4 boxes, and say to yourself, in terms of quality planning, what are we doing? In terms of quality improvement, what are we doing? In terms of quality control, do we have those hurdles? Do we have a way in which our staff are managing the quality by themselves, not with us breathing down their necks, not by quality team coming in, but they by themselves looking at what they do in their own space? In terms of quality assurance, what do we have? Audits, yes, good enough. Who is doing the audits? How are we using it? And then, of course, so there's quality planning, quality control, quality assurance, and quality improvement. How are we doing the continual improvements? What projects do we have in place? Are we using the right methodologies? Are we collecting the data as we should? Are we actually seeing sustained improvement? Thank you.
Thank you very much, Ajibike. So now we all understand once again that that's a great point, that quality improvement is a whole system, basically. It requires lots of elements and not a single element, which is monitoring, which is or auditing, yeah, we can call it different ways, which is measuring performance, which is planning, which is implementing, yeah, and also every staff understanding their roles. Not a single piece can be thrown out and forgotten. Without it, it won't be a solid house, and as Ajibike just said, it would just fall. So every single element matters, every single element is important, and we will definitely talk about it more today. And we see, thanks a lot, all your questions, and we will definitely address all those questions. And once again, I'm sure we will touch on the elements, so you will understand the difference, and we will discuss practical examples. Also, we see that lots of questions are asked about the provision of recording. Yes, we are recording here and also on YouTube. So recordings will be available on our website and also on YouTube page. So especially this announcement is for those who are new to our webinars and never visited us before. And now let's see how one specific hospital had successfully implemented this system, built this system in their facility. Penina, you're welcome with your presentation.
Thank you, Julia. Allow me to share my presentation. Please confirm that you can see it.
Not yet, Penina. Maybe it takes a
Right.
little bit more time.
Is it visible now?
I think it will be opening. We can see your screen, but not yet the presentation. We can see it now. Thanks a lot.
Okay, so I'll start. And allow me not to show my camera right now because my network cannot sustain the two.
Yes, it's fine.
So good afternoon, everybody. My name is Penina Kirea. I'm the Chief Nursing Officer and in charge of quality at Avenue Healthcare. Greetings from Nairobi, Kenya, and specifically from Avenue Healthcare, Parklands Hospital. So who we are, our purpose statement, and I'm doing this on purpose so that you all understand why quality improvement and accreditation that we've just achieved is not possible without the slide that I'm showing right now. Our purpose statement is to enable and maintain health. Our mission statement is to provide high quality care that exceeds our clients' expectation. And you can see on top of our core values is quality. That is the number one amongst others. For the interest of time, I'll not go through each one of them. So this is the outlook of Avenue Healthcare. We have 3 full-fledged hospitals. One of them, Parklands Hospital, which has got a capacity of 131 beds. Thika Hospital, that has got a capacity of 74 beds. Kisumu, 98 beds. That is a total of 303 beds. Besides that, we have 14 clinics right now, and we are putting up 4 more clinics. So in total, we have about 18 satellite clinics that will be running besides the 3 full-fledged hospitals. Of interest today, we are discussing Avenue Parklands Hospital. And this is the scope or what we have at Avenue Parklands. And I'll be going to the next slide, where indicates our quality journey at Avenue Hospital, Parklands, which started way in the year 2018. So in this year, from this slide, you can see we are a hospital that has been in existence for 47 years. So you can imagine this is a hospital that is old enough in Kenya, but the quality journey, I'm just narrowing down to the last 4 years. And the journey started in 2018. And from this slide here, you can see what I've pointed out there. When Evercare joined, and Evercare, I'm just pointing out the ownership of the hospital. It's important that you know that there before the hospital and the whole, the group of hospitals was owned by a family. It was actually a family business. And now the hospital was transitioning from being a family business to a hospital that was now going to be owned by a group of shareholders. So Evercare was one of them. And I will start because this is when we got light, a bit of light of what we really needed to do in our hospital setup. And with coming up of Evercare, it's when we started having, someone coming in to tell us what we needed to do for us to look like a hospital. This is the time that we started setting up structures and standards, the quality standards that we needed to start tracking in our hospital, and a bit of light, basically on everything to do with the hospital. So I'll be explaining in the next slides more of this, so I won't take a lot of time in this slide. So in 2019 to 2020, this is when we did an application for accreditation journey. And basically what happened here, we identified ourselves after realizing that we had so much that was not happening, and now we are putting up things in place. And we felt like we were now running our hospital in 2018. We felt that now it's time for us to identify with an accrediting body. And we chose COSASA. COSASA is a South African accrediting body. I don't want to talk about it so much because I know Jackie is here, the CEO of COSASA. She'll be able to shed more light about it. So initially, what we did, we did a self-audit, which then was initiated and guided by COSASA team. And we were able to come up with a baseline survey. And you can imagine when you wait for a visitor in your house, you will have done so much to make sure that you please them and that you're seen doing the best things. So even after working so hard and having this team in, we actually scored a 48%, and we were like, so what kind of medicine were we practicing before? And staff would make fun of it and were saying, did we really practice medicine before, or was it witchcraft that we were practicing before? Anyway, those were just some of the sentiments that were coming from staff after realizing that there's so much gap that we had that we really needed to work on. In 2020, 2021, this is when we put up a lot of structures, including reporting. And I'm so happy that my colleague that went before me had explained about the measures, about collecting data, because you cannot measure what you do not know. You've got to have a baseline. You've got to have some data that you are comparing, your improvement with. And then this also involved a lot of reviewing of performance. You can only review performance from some data that you have, previous data that you've been collecting. So also it entailed a lot of measurement of standards. Then in 2022, after working very hard, we achieved our accreditation. And now what is happening going forward, I had talk about many organizations achieving accreditation, and when they are waiting for a secondary accreditation, they actually do not make it because they went on a relaxing mode after realizing that they have achieved, so they stop working on it. So for us, we are really focusing on how we can be able to sustain, and we are working on sustainability strategies. So I'll go to the next slide. So a lot of discussion on the role of leadership. And this time around for me, from my own experience in this journey, it called for us to have everybody into the picture. And that is the reason why I'm looking at it like a multidisciplinary approach for quality, reliability, and sustainability. It cannot work unless everybody is on board. And for us, in the first slide that I showed, actually from all the way from the mission and vision of the hospital, you could see that quality was the top agenda. And therefore, what that meant was that unless quality is embraced by the board itself, all the way to the CEO, to the SLT, the senior leadership team, to the last person on the ground, then it cannot work. So why am I showing this? I want to take you through very fast the role of each and every person that worked through this journey. And from the board, here we are discussing the strategic plan, all the way from the mission, vision, and then the strategic plan of the hospital. Quality has to be part of that, and ensuring that this is the point where all the plans are approved. This is the point where the plan is trickled down to every other person in the organization. Then we go to SLT versus the CEO. Again, the mission vision of the organization is also driven by this level, and the organizational strategic plan, best practices are discussed in this level. Then this is the level where, again, the governing or the government legislation requirements are embedded at this level to make sure that we are also acting within the requirements of the government. Take, for example, if we are whatever we are practicing in the hospital has to be approved by the MOH, the Ministry of Health. If it is the Pharmacy and Poisons Board, it has to be acceptable through those boards to make sure that we are compliant at that level. Then at the physician and clinician level, the clinical leadership, we also had a lot coming from this level, because again, this is the level where we have expertise coming in to set up appropriate goals and initiatives for quality plans. This is the level where the clinical inputs are supposed to be worked on, carrying out tasks to meet objectives of the quality plan, motivating staff at this level. And this is also the level where the reviews of plans and supporting staff comes in, assessing effectiveness of the plans as well. The quality strategy must be spoken to everybody for it to actually succeed. Then the quality officials now, this is the level where, again, now quality assurance that has been discussed before me comes in. It is not the team that does the work. This is just the team that comes in to check the work that has been done, just in a manner to quality assure, just to tell people that we are on the right track, we are doing the right thing, but it is not to do the work. And I will, as we continue, I will be able to tell you what we have done before that has worked, that which has not worked. Then the consultative staff here, what I mean here is now incorporating everybody else into the business. And the business here, I mean the quality agenda. It cannot work unless you involve every other person in the hospital. And this, we've tested it before, it has not worked, and until at one given time we had to change the strategy. The initial team that worked before me, of course, sat, and this was a learning journey, and almost everything was done by the team quality. And we realized that we were running out of time. And when we went to actually find out from the team, you realize that the information only sat with the quality team. The information only sat with the unit managers, because that is the only level where interaction was taking place, until we realized that, again, we were not going to make it unless it is everybody's agenda, including the clinical and the non-clinical. So I'll go to this other slide. Again, this slide, these were our key areas of focus. And we looked at the three areas. On structure, we looked at buildings. And in buildings here, someone mentioned that quality is not expensive. It is expensive in a way, but again, if you look at what you're going to save through putting up quality measures in place, then you're going to realize that in the long run, it is going to be saving you a lot of issues. First of all, losses through probably medical legal issues, maybe reputation issues. And again, it's going to be a returning business. Probably when you put up what is required in a hospital, you realize that your numbers in the hospital is growing and your business is coming up, and therefore you're not struggling even paying your staff. You can have the best staff in the hospital. So buildings, we worked on a lot of improving our structures, and this involved a lot of demolishing and building departments. Then equipment, of course, we had to buy a lot of equipment. Most of our departments did not have things like crash carts. We had to redo quite a number of departments like radiology department, lab department, pharmacy, and of course, staff issues. We had to recruit the best staff. We had to make sure that we had the qualified staff, because initially, again, we did not have qualified staff in all the departments. We had to make sure that the nursing department, we had the right ratios for us to be able to actually offer quality. There before, we had crazy nurse-patient ratios that were really not giving us good results. At the end of the day, you have fatigued staff and that do not even want to come back to work. You have staff all of a sudden taking leave, all of them sick offs, and therefore the productivity went down. Then also you look at the supplies, you're able to get a lot more that you are not getting before. So on policy, on the processes, again, we had to do a lot of development, redevelopment, and reviews of policies, making sure that the standard operating procedures are accompanying policies. And besides now, the policies and standard operating procedures is to make sure that you do not only have them on paper, but you're having them being practiced. And how we measured this was to make sure that at least when you interview staff, they are able to tell you a process, a policy, because you see, it is only through this knowledge that you're able to tell that staff know about them. Then the next thing is when you observe, you can be able to follow through a certain policy, a certain standard operating procedure, and you're able to tell. For example, patient identification policy. You do not, you would want to find out from a staff their knowledge. They can verbally tell you about it, but you can also sit and observe whether that is put in place. You can also follow that through documentation check. That is both open file audit and closed file audit. Also on processes like turnaround times for all departments, service delivery points. I may not go into thorough discussions on that for the interest of time so that I don't eat up time for the others. So the outcomes, again, this was also another key area of focus. And when you look at this again became the outcome of now all these other measures that you had put in place. And what could tell us that we were doing well was measuring, and this again came from the person who was discussing before me. How well will you tell that you're actually doing well after putting in money? You have bought equipments, you have had the best staff in, you have trained staff, you have had a lot of supplies in, and now you've put in your policies and procedures, and now you're measuring them. This is the outcome is what will tell you whether you're actually doing well or not. And this again came in through the mortality rates that we recorded in the hospital, the infection rate, patient satisfaction, and incidents that we recorded. So what are the challenges? Challenges, we were able to, lack of knowledge, of course, which we carried out thorough training for our staff. Lack of buy-in from implementers. Then in this lack of buy-in, we had to do a lot of training, a lot of convincing and telling the staff the benefit that would come in improving quality of care in the hospital and safety of patients. Lack of motivation, which we overcame this through intensifying the whole process, best projects, failure to establish a team. This again, we kept changing our strategies on how then we approach the team. Then failure to establish gap problem areas and RCS. We had to train a lot so that we kept now improving and reviewing all the incidents and through RCS that we carried out. Resistant to change, again, culture issues. We had to deal with a lot of culture issues. And as at now, I'm proud, I can be able to say that we did quite a lot and we can see a whole turnaround of culture issues within our organization. Operating in silos, failure to test changes in smaller scales. This we have overcome, and now we have been able to test through smaller bits, and now we can be able to tell a story for the whole organization. So having said, having taken you through all the activities that we did, this is a success story because this is the scores that we got. Look at the blue color, because this was the baseline survey that was done by the external auditors. And the red one is what we scored in the long run. And after the discussion that I had initially was after we had put all our efforts, we really got discouraged at first after getting 48.8%. And now that is when we sat down and we asked ourselves, then what else? What next do we need to do? We put in our all, we worked so hard, and we attained a score of 96%, which is as at September, that is 2 months ago. It was a success for us all, and the team really was very excited after going through all the toils. Then lessons learned through this journey. Leadership support and involvement is very key in the whole of this journey. Then inform staff and organization strategy. You have to put your staff into the picture from the word go. You sell the big picture to the staff, offer training and allay anxiety, then seek their input and delegate the quality improvement projects, then reward innovation. Then teamwork is very key and build a culture that values quality improvement. This is just an explanation of what we've had before. And the methodologies that we adopted through all these processes was fishbone problem analysis, 5 whys. This was just in a way of problem identification and through RCS, then PDSA cycle for quality improvement. And this is just in a manner to just show you some of the projects that we've been able to carry out. And I can be able to confidently say that our staff right now are very comfortable. They have acquired a lot of skills to be able to carry out projects comfortably. You can imagine this is a graph to show you how where we've come from in terms of 4 rates within our organization. And if I'm given time, I can actually tell you very bad stories that came from here, because the reason why we came up with this as a project, 4 rates as a project, it's because we got 2 very bad sentinel events that came from these falls that costed the hospital about 20 million payoff through medical legal issues. So this attracted the attention from everyone, including the board. So we had to narrow down to, we had to just sit down and say, we can't continue working like this. So after that, putting a lot of measures in place, then right now we are not able to record any fall, or if there's any, it is just a very minor thing that is not going to cost the organization any. Reputation for the hospital has really improved through NPS score, which now we are recording at 75%, all the way from less than 30%. So this is perinatal mortality. You can see where we came from. and where we are right now as a result of putting in quality metrics in and constant measuring every month and discussing and putting in quality improvement plans in place. And this is also a project that we did, and you can see how well we are doing there. And this is maternal mortality, again, complications, sorry, that are coming in through our maternity, doing quite well. And this is our cesarean section rate. Again, this is a project that we were carrying, and you can see we are down all the way from 45% to less than 10% at the moment. This is the documentation compliance, and this is just to show you what we were before. This is a medical records department that was nothing. You can see it's all cluttered before and after, all the way from a department that we did not even have a single policy. You can see you could not even retrieve any document from the medical records department before, and there was no safety of medical records department, and you can see the after. It's really very well done. And preparation mode and after, we were very happy, and now we are working towards sustainability to make sure that we remain within the same standards. Thank you, and that's my presentation.
Thank you very much, Penina. Such inspiring example. And we receive actually lots of comments that this is really great achievement in a relatively short time. And I would agree. So obviously to get accredited within that period of time, you really needed a very well-structured quality management plan. That's no doubt, because time was used very effectively. So thanks a lot, Penina. And before we move to the next speaker, I actually wanted to make another announcement. I have shared the link to our free online training module that IFC team developed, which is called the Foundations of Quality Management or Quality Improvement, whatever you call it. Because one of the most common questions, especially after hearing such stories as Penina just described, is, okay, if I want to do it myself, if I also want to be like the Avenue hospitals to get accredited quickly, to build the quality system, I need to develop those documents. How will I develop them? All of these terms, scientific terms, and we receive questions that something is still not yet clear. We'll definitely address this in questions and answers. What's the difference between plan and program, quality management, quality improvement, quality assurance, quality auditing? Quite overwhelming, I agree. So if you use the link which I shared in the chat, you will have a very clear overview of all the key elements that Dr. Ajibiki described. And you will find lots of answers, lots of useful downloadable materials and outlines and documents. Once you decide to build a quality system in your facility, what needs to be done and what are the documents, you will see real life examples. But we'll definitely talk about it today more. It's just additional source of information that you can use. So this was the story of one facility. Now let's move to our next speaker, Jackie, and hear about some other facilities that also were successful in implementing their quality improvement programs, plans, etc. Jackie, over to you, please.
Thank you, Julia. Let me just share my screen. Oops. Thank you. It's really lovely to be here and to have such a lovely and high number of participants. So I think it shows the level of interest there is in quality. And I saw one question in the Q&A where someone said, with the brain drain of qualified and clinicians from Africa is having a real impact on our quality improvement efforts, what do you suggest we do? And my answer to that is we continue with the quality improvement efforts, because a lot of people are leaving because the environment in which they are working is not conducive to providing good quality healthcare. So we've got to find ways to make it work. As Julia said, I'm the Chief Executive of CASASA, but I'm not just here to talk about CASASA and the quality program and the accreditation program. I also want to talk about what I've seen in some of the hospitals and clinics that's made it work. And how do you make a quality program, develop from your quality program, your quality plan, and then get it implemented? What I'd like to start off saying as well is I had the absolute pleasure of phoning Avenue Parklands, Avenue Healthcare Parklands last Friday to tell them that they had achieved full accreditation. So it's always my happy day after the board meeting to be able to call them. So that was the absolute great news. Unfortunately, I couldn't get through to Penina, but I got through to her colleague. So it was just a real joy to be able to tell them that news. The bad news is, Penina, this is just the start. I know you're all celebrating and having parties right now, but this is just the beginning, because Ajibike referred to accreditation as part of quality, as quality assurance. And I firmly believe it is quality assurance and quality improvement, because as you go through the program, you implement more and more improvements. And the external survey, when external people come and look, that is a quality assurance exercise. But getting to that point is about improvement. So it's I firmly believe it is both quality assurance and quality improvement. And I believe as well, the value of an accreditation program is that you do have an external body coming to check and saying, yes, you do meet up to the standard. But it's not just about complying with standard, it's about a culture of quality that is embedded in everybody in the organization. And I'm going to touch on things that both Ajibike and Penina have talked about, but I think it's good that we do some repetition in this. So starting out in the program, what is really important is right from the outset is to get buy-in at all levels. Just excuse me, take a sip. So that's from the board, the management, the staff, and I would also suggest your patients. When you embark on any kind of improvement program, find out from your patients what they think of the existing service and start to raise their expectations. There was also a question in the chat about how do I know when I've achieved qualities, when I meet the standards or meet my clients are satisfied? And my answer to that was, well, your clients' satisfaction may depend on their expectation. And I'm sure we've all been into those facilities where people are just expect to sit the whole morning waiting to see a doctor. And if somebody said to them, what's the service like at your hospital? They go, oh, well, we wait a long time, but that's it. That's what we do. So I think taking your patients with you on the journey is important, because you're saying we know we're not doing everything perfectly now, but we're trying, and that trajectory that Penina showed, we're trying to get there. Second, you need to make sure you've got the resources, and this is not always easy. Have you got enough staff time? Have you got the equipment? Have you got the information systems? Have you got a preventative maintenance program that when you build all those new buildings, if you have to build them, there's somebody to look after them? And on many occasions, we find facilities do not get up to the level for accreditation because they have no preventative maintenance in place. So that I give you that as a right now start. When you're starting, it's no good just painting it and think the surveyors are going to think that's good. We want to see a preventative maintenance program for all your equipment, for all your facilities, for your plant, right across the board. Staff time. I would suggest the further you move on in the improvement journey, the more motivated your staff become, the more productive they become. So being short-staffed doesn't mean you can't do improvements. You can actually motivate staff by saying, how do we do things better and more efficiently that will make better use of your time? The information system we're all moving into technology now. Let's try and make sure all our information is available and that we know how to, what to collect, what data to collect that we're going to measure, and how to do it effectively. And if we can do it in a system rather than on paper, you're going to lose less data and it's probably going to be more accurate. But it's not essential, but there. Then education and communication. I cannot emphasize these enough. If people don't know what they don't know, or you don't tell them what they're meant to know, they're not going to do it. They're just going to be blank. And it was very interesting hearing Penina talking about convincing people that this was the right way to go. And I put this one last, as quality is an integral part of the culture, because unless you've done the others, you will never have quality as an integral part of your culture. That comes over time. Culture develops, and it won't happen straight away. And again, a warning to Penina and the team. I don't think it will happen with them because she is certainly a very driven woman and they have an exceptionally good team there. But it is very easy to get to the top, what you think is the top, and stop. And then you let things drift. And then it's like, oh no, we've got another one coming up. We're going to start again. It's about this continual cycle of improvement all the time. You do the right thing because it's the right thing to do, and we do it because even when nobody's watching. And a very small example of that, when I was still nursing on the wards, I think nutrition is a key part of patient care. And this is a very small thing, but it was important. And we used to give the patient soup in the evening with their meal. And I said, people going down the ward dishing the soup, and by the time it got to the end, the bowls were cold and the soup was cold. So I said to them, please warm the bowls and warm a jug and put the soup into a warm jug and keep it covered. So when you pour the soup just as you give it to the patient. And one evening I was in my office, and as I went past, I heard somebody saying, oh no, Jackie's on, quick, go warm the jug. And I walked out and I said to them, I don't eat the soup. It's not for me. It's for our patients. So, small example. I just put it out there that I believe our internationally accredited standards are a blueprint for good practice. They don't tell you pretty much anything that you wouldn't know already, but it's about in a format that says these are the things you need to have in place. And if you put them in place, you will have all the things that you should have in a hospital in terms of systems and processes and behaviors. But on your journey, the whole thing about planning and preparing is you need to tell your team where you're going. You need to tell them why you're going there, and you need to tell them.
Varda, I'm sorry, we hear in English channel French again.
Sorry. Why? And you need to tell them how you're going to get there. Because I have seen so many times an accreditation program be introduced at a regional or provincial level, and the hospitals get told these people are going to come and do this to you. It happened one time where our team arrived at a health center in one country, and the driver spent 2 hours negotiating to get the team to be allowed in because nobody from the district management team had bothered to tell the health center that they were part of this program. And they just saw it as some more external people coming to do something that was going to last for a little bit and then go away again. And I'm happy to say we went, we worked, and we stayed. And it got embedded really well. So it's really, really important that people understand why we're doing it. This is what we're doing and why we're doing it, and these are the steps. And again, I think I'm repeating what Ajibiki said. What is everyone's role in this journey? Do they understand what they're doing? Because some people will think it's just the quality coordinator or the quality manager, but everyone, every single person in the organization has a role. And that's critical that they understand what that role is. And I think this goes back to the First World War or something, but a saying that says nothing is ever lost in good planning. So it's not a journey, any improvement journey, don't just start it, inform everybody first and plan it and know exactly what you're going to do. Of course, there'll be challenges. Of course, we will make mistakes on the way. We're human, but make sure you've planned it. This is, I just took this as an extract from a presentation that was done. She was a quality coordinator in a district hospital in a rural area. And she wanted to explain how they had put together the program. And she said, I just picked out phase 3 of their communication strategy. So they had the services being visited, and they had set out a program of how the services would be visited and would be assessed against the standards. And importantly, they said, whatever was going to be developed would be put into an evidence file. So they would make sure they had an evidence file, and then they would develop plans to make sure everything was followed up properly. The reason I'm really showing this, though, is they had open days and exhibition days for night staff and for day staff. So again, it wasn't just something that happened during the day. They actually put on, and they went during the night and helped the night staff to understand, because they had permanent night staff. So that was really important. And then they had a quality week. And this was right at the beginning of the program to get everyone involved and everyone to understand what they were doing. And they had about 5 phases of this. And part of that was also benchmarking with other hospitals in that regional area. And that, again, is something I would encourage, is to benchmark. I know most of you are obviously in the private sector, and there may be some commercial competitive reasons for not doing it. But you can always benchmark with someone outside your immediate area. But I know we've got colleagues from Uganda here, and I know that has certainly happened in Uganda, where the hospitals have kind of shared their knowledge and done some benchmarking. And certainly in Kenya, we've seen that as well. Moving along and into your planning, identify your leaders and champions right across the board. And this is not by position. This is by people who can be a champion within any department, and they don't have to be on the management team. Interestingly, the coordinator who wrote the previous slide was a speech therapist. And when she started she was the chair of the steering committee. And when she started that role, she really struggled with chairing skills. She struggled with asserting herself. By the time they reached the accreditation, her view was it was the most beneficial personal and professional development she had had in her career. And she shone, absolutely shone. So don't think the leaders are necessarily there by position. I have seen great champions in laundry, in the food sections, in one of my favorite champions was a mortuary, the mortuary technician. And he took great pride in showing me the old mortuary, which was horrible. I mean, just awful. And then he showed me the new mortuary, and he was very proud about this. But he said to me, the problem is they didn't ask me about what needed to be here. And I haven't got the pictures with me now, but he showed me that in the old mortuary, under the table, there was a pipe that went straight down to the drain. In the new mortuary, the pipe had 2 90-degree angles in it. And he said, how am I going to make sure that gets cleaned? In the fridges for keeping the bodies, there was only the space of a ballpoint pen between the racks. So he said, I have to take all the racks out of one side if I want to get in to clean, because I can't get in between the racks to clean. And the door didn't close. The door stayed open about the width of a pen. So he said, I don't know if I'm ever going to be able to keep this clean. But his absolute piece of pièce de résistance was that they didn't give him, the supplies department didn't have a mop for him. Now imagine a mortuary without a mop. So he sluiced floors during the day, but at the end of the day, when he wanted to mop them, he borrowed a mop. And he borrowed it from the administration block because he said, that way I won't affect any patients. I don't know how long it took the administration team to find out that their mop was being used in the mortuary, but he was a great example of a champion. I think he got a mop very soon after he told me the story. Communicating with everyone in the team to ensure they know what is expected of them, because I won't do something if I don't know why I'm doing it. So if you help me understand why I'm doing it, I'm much more likely to comply and to do what you would like me to do and do it with intent. We need to train people, but it's not just sitting in a classroom and training. It's about coaching and supporting and encouraging at, as I said, all levels of the organization, and giving people practical examples, being visible as the management and leadership, be visible and make sure that people know it's important what they're doing and acknowledge them. I've seen as people move through the improvement program, I have watched, they kind of grow a little bit in stature because they start to see their scores increase. But more importantly, they start to see the whole environment improve. They see the teamwork improving. And the cleaners move their mops with a little bit more gusto, and everybody just seems happier. So, and it's because they feel supported. If you just do it top down, it's not going to work. This is an example. This is a maintenance department, and when this was a complex, 2 hospitals that were together as a complex, and when they embarked on the program, she was then the deputy director of nursing. She went and talked to them because she was the coordinator, and they said, we don't know what we're doing. We have no idea what this is all about. So she said, okay, my babies. She always called everyone that. I will come, and she took the coffee and she took the biscuits, and she said, now let's just sit down. Let's take an hour. Just do it for an hour. Now tell me what you do. Tell me how you do your job. How do these machines work? How do you know they're working? How do you look after them? And so they started explaining what they did. They explained about the checklists that they had to use to make sure the machines were working, that how they checked the generator to make sure that it functioned, that it didn't just switch it on and off, but they put it under load to make sure that it really would work when it was there. And slowly they talked through all the things that they did. And she said, you see, you know how to do it. They never had to write a policy. So she helped them with writing their policies, but they told her what the content was. And this was a great example of teamwork, of how to do it. Use different people in different places. Identify those champions. And she eventually had this maintenance team. They were so proud and so motivated. The workshop absolutely shone. It was just a beautiful example of how somebody had taken the time to coach them. She didn't sit them down and train. She just coached them. What do you do? And they knew what they were doing, but putting it into the right words for it to be an improvement. What were the things that they were measuring? How could they identify indicators that were relevant to what they were doing? How could they measure those? And then she taught them how to do run charts and how to just very simple things that would show that everything was improving, and their scores improved dramatically. But most importantly, they were such a motivated team. Another element I've seen is where they put a little bit of competition in, and I think it was Ajibiki said, and in fact, both Panina and Ajibiki said, you know, each department contributes to the whole. So it's one for all and all for one, but there's still a little element of competition between departments. And that is very healthy, because you want to share what's good and you want to help people when they're not doing as well as they might do. How do you encourage them to do more and refer them back to the plan of where we're trying to get to? How do we get the data to measure where you are? But it's also helps people to step up just that little bit more and do what they really think they want to do. And the result of that was this. This was the laundry team And I don't think they'll mind me saying this was a hospital called Arapa Mine Hospital in Botswana. It's right out in Arapa and on the Botswana mine. And the laundry team had the most improvement from their baseline to the external survey. And can you just see the happiness in that? And that's what it's all about. And they've been accredited now 5 times. And it's like the quality improvement is in their DNA. They all know what to do. They do it efficiently. When somebody moves in newly into the organization, they're orientated regardless of the department they're in, and they really believe in what they're doing, and their clients are very satisfied. Thank you. I'll leave it there.
Thank you so much, Jackie. This was so interesting to hear, and thanks a lot for all real life examples. They always matter a lot and make a big difference. So now we're moving to our question and answer session, and we are a little bit running out of time, so we will be definitely staying longer. So thanks a lot for staying with us. We hope you will find it useful. As always, we receive lots of questions, I think even more than usual today. Most likely we will not be able to address them all, but we'll definitely put the most interesting ones with answers into our community of practice, as usual. So you are welcome to join. The link was shared in the chat, but probably my colleagues will share it once again so that you don't need to scroll. So, question of the day to all the speakers, maybe each of you will be able to contribute something. So let's repeat once again, what is the difference between quality program and quality plan? It was repeated several times by our audience. What is the difference? Let's explain once again.
Can I start? So I think I already responded. So a quality plan, I mean, just the way it to be interpreted, whether it's a project plan, and actually talks about how you will implement your program, or whatever it is you have, your strategy, how you would implement it, what are the things that you're going to do. What we're saying is, right now, and many hospitals are doing it well. They already are doing it well, but we're, so speaking for those who are not, is in your plan, you need to, or before you write your plan, you need to think through all the things that need to happen. And I would use the analogy of a house again. A quality program is like a house. Before you build that house, you will plan what you need to do. There are very few people, if any, who will just wake up one day and start digging and building a house. You will need to think through what you're going to do and make sure you have all the elements in place so that you would, before you start, so that you don't miss out anything. So when you're talking of your plan, you're thinking of your vision. What do what's your vision? What's your mission? What's a strategy for the hospital? How do you put all this together? What do we want to do? How do we want to provide the best customer service? How do we want to make sure that our services are operating efficiently? What's our plan for our staff? How do we keep our staff engaged? Then by the time you think through that, even though it's going on at the same time as other work, so I'm not saying everything has to come to a stop to do that, but some people have to do that thinking, because that way you now have a plan for how to implement it. So you write into your plan what you're going to do to implement your program. Okay, so that's the difference. Sometimes different types of plans, really. So it's not like there's any one type of plan that is the plan. There are different ways of putting in your plans. I've seen some really lovely plans in Excel sheets, right, that take each aspect of what they want to do and they're clear about it and they share it so everybody knows what we want to achieve. Some hospitals will merge it, different things. So some will put their program and then the plan at the bottom. So, but the most important thing, for me, that I want you to take away is knowing that you have to plan all the aspects, including how the staff, the staff responsibility for controlling quality at their end, how we're going to do assurance, how we're going to be doing continuing improvement, such that by the time, like Avenue Hospital, you get that accreditation, you're able to stay with it because you're continually improving. And I must take this opportunity to say congratulations to Avenue Hospital. The accreditation, I'm blown away. But more, I love the charts, those charts that are going down and going up where they should be. I think that's awesome. Congratulations.
Thanks a lot, Ajbiki. So just to make sure I got it right, so does it mean that the plan is basically the actions that need to be taken and it's part of the program and the program is a system? Can we say it like that?
That's the way I see it, right?
Okay.
So the system, there's an umbrella. So these are all the things we will do. This is our mission, our vision. You saw what Avenue did. So based on our mission and our vision, our values, this is how we want to do our work. Then you have a plan that says, okay, great. So now that we have all thought through what we want to achieve, how do we do it? So we're going to adopt a particular methodology. We're going to look at these priority areas. Then we are going to seek accreditation where we got to this point. Then we're going to, develop a safety culture and we're going to assess our culture. So those are the, it's like coming from a strategy and then your operational plan. Okay.
Thank you very much. Jackie, anything from you on this point? I thought you wanted to unmute.
No, I absolutely agree. In my world, the program is the system and the plan is the how-to. And all I would say to people is try to keep your plan as simple as possible.
Thanks. That's a very valuable point. Yeah, that's a great point, because try to avoid scientific language so that no one understands what you actually want from them. Also, keep your targets very clear and simple, so they should include just one action. This is my favorite example, which I keep repeating, so maybe many of you already heard about it. There is a gap that there are problems with, say, hand hygiene program, and the target cannot be improve, the action, sorry. The action cannot be improve the hand hygiene program. Of course, it is your target, but it has lots of sub-elements. What actually needs to be done? Do you need to install the sinks or improve your hand washing facilities? Like improve, put the sinks, ensure that all taps are working, or maybe add the soap or paper towels, make sure it's always in place. Or what, maybe you need improvement to train staff. Maybe staff do not know about how to wash their hands. So actions should be very clear, straightforward, measurable. And for each action, there should be a responsible person and a deadline, because we cannot say, yes, this is, by the way, I'm now talking about actual planning, yeah, the Excel sheet that Ajibiki described, because program will be broader. So if we're talking about, for instance, certain action, and then we say, yeah, you understood, you need to do this thing. You need to ensure that everything has a soap. By when? Because then people just forget about it, and then nobody's looking at the paper, at the spreadsheet, and then suddenly after 3 or 4 months there is an outbreak of infection, and you say, oh my God, I think I told you to put the soap. Yes, but you didn't tell when. So there should be deadline. There are important elements even for the plan. Okay, so the next question, actually, we talked about accreditation a lot. Obviously, accreditation is a kind of stamp of approval that, yes, there is quality culture implemented. But if not yet accredited, what indicators or what signs can a facility use to make sure to say, yes, we actually have robust culture?
Ajibiki?
Okay, I mean, I've been thinking about that. So if not, well, for me, there are a few things. One, to make it simple, your customers, if you listen to them, will tell you. You would hear from your customers, you will hear from your staff. see it in your bottom line. You will see it in how your services operate. You know, just walking through your hospital, you will know. So that's the very, very basic one. But there are other tools that, you know, some of the data you collect, if you know, make sure you're collecting reliable data, not data that tells you what you want to hear, but data that tells you what is, right, would also tell you. And then there are other tools, other assessment tools that you can use. So the Baldrige self-assessment tool, for instance, is one of the ones I like for operational excellence, organizational excellence, where you can by yourself, you know, actually go through to look at how are we doing in compliance with this. You know, looking at patient safety culture tools that are available free online to assess how you're doing in terms of safety. There are quality assessment tools that are available free that you can also use. So it's not one thing. I don't think there is one thing, but the other thing I would say is try to use what is known to actually measure your organizational excellence. You know, if you want something that's objective, right? So some of these tools that I've talked about, or international indicators, you know, of data that you can benchmark yourself against. I hope that helps. Jackie?
Yeah, I think again, it's don't overwhelm yourself with indicators. Select a few areas that you're going to measure, and particularly at the beginning, start with measuring a few things that are really important, a few priorities, and then as people get used to that, then you start to roll out more indicators, but keep it to things that are measuring something that are genuinely showing you it's a priority for either patient care or a process that is helping your organizational function well. It's really important. And Penina might do, because she showed us some great examples of indicators they've measured. So maybe she'd like to comment on a few.
Thanks, Jackie. Exactly what I was going to say. So we actually, while we were discussing indicators, Penina mentioned impact on patient outcomes. So I was going to ask Penina, maybe she can share some more indicators that they were using even before accreditation, just to make sure how well they are doing. Penina, can you please share?
Yeah. So yes. So from my discussion, all the way from the first slide, I hope you can hear me still.
Yes, wonderful.
Yes.
We can hear you very well.
Yeah, so from the first slide that I presented, I mentioned that in the journey, the quality journey that we began, and by the way, I need to just make it clear that from my own perspective, quality accreditation is not everything to do with quality. Our quality journey started all the way from the year 2018, and in a hospital that has been in existence for the last 47 years. So 2018, why? It's because this is the first time we got someone coming to open our eyes, to show us that we needed to do things better than we were doing. How would we have known that we were doing things better, in a good way? We wouldn't have known if we were not tracking something. So this is the beginning of good things. That's what I will say, because again, this is the first time when we got some indicators in, because with the coming of Evercare, then we had some indicators, clinical, I'll say clinical because we looked at quite a number of areas, and I'll mention some of them. We looked at patient experience, clinical pathways, IPC, patient outcomes, and patient outcomes here, we're looking at, incidents that are associated with the patient mortality and all the other outcomes. So efficiency, everything to do with turnaround time. How do we have known that it is a problem, a patient coming to sit in your outpatient for 2 hours waiting for care, or simply waiting for a lab test that would only take 30 minutes? You know, a patient making noise that they have been sitting in outpatient for the last 5 hours. It would never be a problem for us unless a patient came up and tracking over time. So yes, it doesn't have to be through accreditation. You can always have indicators that you're measuring yourself with, but again, it has to be acceptable with the world, benchmarking yourself with acceptable standards. That's what I'll say.
Thank you very much, Penina. Jackie, you wanted to add something?
Yes, just can I add one? I don't know if it's possible to, we haven't got all their yes, no buttons, but a question that I would ask you all to ask yourselves and your staff. And this is probably for me, the most critical indicator. Would you allow yourself or your family to be treated in the hospital that you work in? And if your answer to that question is no, then you have a serious problem and you need to sort out some indicators really fast.
Thanks, Jackie. That's a great point. Actually, that should be indicator number one for all of us to begin with. And then, like in a flow chart, if you answered no, then it's a disaster. If you answered yes, then follow to other indicators.
Yeah.
This is a great example. Yeah. So another question, and by the way, we receive lots of questions about the templates of quality plan, quality program. And let me once again remind you about the online training modules. I'm sure you will have all the answers there and lots of useful materials that you can fill in and print out, and it will be a ready-made document for you. So I will pass the floor after we finish with question and answer session. I will pass the floor to my colleague Natasha. She will once again walk you through and tell you how to find the modules and where they are located. And it's very easy to access them. But meanwhile, we'll take a couple more questions. I understand you might be all tired, but we still have a little bit more time, although we are still running late. One more question, Ajibiki, I know you answered this in chat, but still let's clarify once again, because it keeps being recurrent, the difference between the terminology, quality assurance and quality control.
Okay, so first thing to say, please don't get hung up on definitions. So that because I've seen all kinds of questions about where do SOPs fit in? Is it quality assurance? Is it quality improvement? Don't get hung up on definitions. They're just guides to help you know what else to put in, how to flow and all that. So in terms of quality assurance essentially, from my understanding, is how do we meet standards? So you and checking how you're doing in relation to those standards. So if you must have a set of standards to be able to do quality assurance. You must have targets, you must have best practices, you must have clinical guidelines and things like that to be able to do quality assurance. And then you work to meet those standards, and then you're checking to see whether you've met the standards, and you are working to close the gap for the standards. Now, quality control is what you do almost essentially on a daily basis. So you're inspecting your work. As you're doing your work, you're making the changes. As you're doing your work, you're checking for those gaps and making the changes. Quality assurance is almost like, they're very, very similar, but oftentimes it's more about somebody coming in to check. Okay, have you met the standard? And like I said, it can be even in your hospital, right? You can have a peer come in, you can have your quality team come in, you can look, but usually quality assurance is after the fact. So you have done the work. At the end of this month, we check how we did this month. Quality control is the one that you're doing on the spot, right? So you come in the morning with your team, you have a meeting and say, how fall? Why did we have a fall? What are we going to do? What's our data looking like? What's our work looking like? What do we expect to happen today that we can work to, to prevent or to improve, or what, something like that. So quality assurance, usually it's that's why they say it's reactive, right? Quality control is almost like proactive. You are continually checking. Quality assurance after. So quality audits, whether they're clinical audits, non-clinical audits, for instance, are quality assurance, helping you push towards the standards or the targets that you want to meet.
Okay. Thanks a lot. I believe this is super helpful to clarify all these things. And actually now a related question, and we'll take just a couple more before we wrap up. Related question. So how often, once we talk about checking, how often do you need to check the fact that you are following the standard? And basically a relevant one, sustainability. So once you develop the quality plan and program and everything, how do you make sure that it's sustainable? So any tips, any advice, and also frequency of checking. I know, Ajibiki, you partially answered, yeah, on a day-to-day basis, etc. But like, what the system of checks should be, what optimal system should look like?
Maybe I'll let Jackie and Penina say something before Jackie, Penina.
Penina, do you want to go first, or shall I start? Do you want to carry on?
I'll go first.
Okay. I think I'll answer it backwards. Sustainability is, once you've got there, you've got to stay there. And that's about how you have worked your way through the improvement program. What I have seen is, as people improve, and the services get better, and as that gets better, their working environment gets better. And you start to see people just behaving better, more motivated, and just keep that going and make the measurement of things that are actually important to the staff and to patients, and acknowledge people for doing that. Make sure they understand why they're collecting data, how to measure that data, and what the results are of the data that they collect. The frequency depends on what you're measuring. It's no good saying you measure everything once a month or you measure everything once a week. It depends on the indicator when it needs to be measured. And if you measure something too often, you're not going to get very good results. If you don't measure it often enough, you may not get good results. So it's also try and find the people in the organization who've got skills of analytics, because that really helps. But take your clinicians on board. Don't say to clinicians, we're going to measure your length of stay, and condemn them because their length of stay is too long, without helping them, getting them to explain what the reason is that patients are in for a certain period of time. It's about making sure the data translates into real information that people believe in and that is useful to actually improve your services.
Thanks a lot, Jackie. So Ajibiki, Penina, anything to add?
Yes. So in sustainability, what I think works, once you put your systems in place, and the systems are working, for me, I don't have to be there, because we have done this before. And of course, we've failed on several occasions, because we felt that at first we got it wrong, because we thought that the quality team, the team that we thought was quality, and I think that was a wrong interpretation. Just a few guys seated in the head office and thinking that they can be able to carry on quality issues and they're able to succeed did not work. Because again, we did not involve everybody in the quality agenda. So once the systems are in place, and I mean, when we talk about systems, are your processes in place? Are, policies in place? Have you made sure that everybody understands then what needs to be done? Then tracking over time and making sure that that is the culture. You build that into the DNA of everybody works within the organization, and that they all understand the reason why they must do it. Then for me, that is a process. Then you need to continue monitoring closely, and you are assured that it is going to continue working. Then involving the doer of the job, you'll be amazed the kind of ideas that come from the doer of the job. I mean, the frontliners. These are the people who sit with solutions. They know their problems, and they still the team members that have the solutions to their problems. So this for me has really worked. And also now sharing data. Once audits have been done, share data with the teams, again, share data with the leaders, be candid with them and show exactly how the situation is. You know, with data, you're able to argue your point and anybody will just come in and just be convinced on what you need. That's how I have won.
Thanks a lot, Penina. Actually, that's a great point. Speaking about the leaders, we have the last question, and this is a very important, very challenging question. Okay, there is a team that wants to do quality improvement. There are champions, everything is in place, but how to bring leadership on board and make sure that they also are ready to invest in quality and not only focus on the revenue and finance. And by the way, this is very relevant again to our contest, because the data, if you share the data, would be great factor to persuade the leadership to invest in quality, because there is a correlation with the business case. So how to bring leadership on board, how to make them support the quality improvement actions, because not always it can be done just by the quality team. Sometimes it needs financial support and also, of course, psychological support from the leadership, and this example setting is very important. So how to make it? What are the tips and what are the tricks?
Okay. Yeah, Jackie, please go on.
Yeah, I think Penina just touched on it very eloquently by saying, when you get all the data and you can argue your case very strongly. So a few examples that I would give, if you've got a leadership team that does not believe in quality, go and count your adverse events. Go and count your length of stay. Go and look at your readmission rates. Go and look at your infection rates and try to cost the financial cost of those things, just those 4 things, and then try to put a human cost to them. But the financial cost of just those 4 is phenomenal in a hospital. And the 5th one I would say is measure waste. Because, I mean, I used to see horrendous things like a doctor pulling out a cannula and going, oh, wrong size, throwing it in the bin and pulling the next one out. This was in a hospital where we weren't billing patients for items. You sure wouldn't do that in the private sector. People taking anti-embolus stockings and measuring them against the patient's leg and then throwing them back in the cupboard because they didn't fit. I mean, waste, waste, waste. So show them the cost of poor quality, and I'm sure that they will buy into your program.
Thanks, Jackie. Ajibike, anything to add?
I mean, I think Jackie has said it absolutely well. You know, leaders, I really would hope that most leaders would want to do quality ab initio. You know, maybe they don't know how and next. So I hope they won't be too difficult to convince. But most leaders will respond to the financial issues. So look at where the money is leaking out from. If you start from there, right, and you know, give them data continually and show them improvement. So don't just bring your data, throw it in their faces and say, oh, we need to do quality. You must follow up. You must be showing them that whatever they're investing in quality now is actually helping to achieve those goals, and it's keeping the patients happier. So because as you then, you know, improve your quality, show them the numbers, show them the ratings, show them responses from staff and your patients. That will help. It should help.
Thanks a lot, Ajibike. It was such an important question. We couldn't skip it. It was great to discuss it once again. So, Penina, you wanted to add something? Yes, please.
Yes, I just want to support the 2 ladies who spoke before me. And just to emphasize on the financial bit of it, you know, every leader, and especially at the board level, at the CEO's level, financial issues will always attract a lot of attention. So for my case, and you look at the IFC form that you're showing everybody, that you're asking everyone to fill. I already submitted mine because I did a project And you'll be able to see from the project that we did. Actually, we were looking at, let me just peel the beans. We were looking at patient falls and the costs. And I was just featuring on 2 cases that costed the organization quite a lot of money, you know, which were sentinel events. And we would not have known that they're sentinel events if we were not measuring this. Because before, in the last 46 years, you know, how else would we have known that we had sentinel events if we were not measuring? Of course, there were so many other cases that went without anybody's knowledge. Before, there's no one who knew what a sentinel event was all about. You know, it was okay for us to just come and give care to patients and they just go home. Admit patients, they're okay, they just go home when they are done with their stay. You know, if a patient fell in a hospital, it was nobody's business, you know, until someone opened our eyes that, you know, falling in a hospital can cost you. And we are living in a world that everybody now is so enlightened. They know that they're coming to be safe in our hospital and they should not be harmed in our hospital. Anyway, to cut the long story short, my 2 sentinel cases costed the organization 25 million Kenya shillings.
Wow.
25 million Kenya shillings, that one will put up another floor, you know, or it will put up a whole quality department with all the skilled staff that you need. So, or equipment that you need in an organization. So anyway, if you cost it like this, then you're able to show, but you cannot show if you're not tracking your data, you're not sharing your data with management, you're not sharing your data with staff, for them to be able to see that it is also something that can cost them as professionals. You know, when a litigation goes bad, nowadays they are going for you as a professional. Did you do your right thing? That's what I would contribute.
Thanks, Penina. Exciting. This is so exciting to hear that you already submitted this case, and these are great examples that you provided. This is really shocking when you just think about it. It's so great that you described this case because it's conspicuous, and also thanks a lot for submitting. So if anyone else wants to submit, you're welcome. We shared the link. Also, just send us an email and we will email you the form if you didn't see the link, and you will be able to submit your case just as Penina just described. It's very easy, but this information is so important for all of us, for the whole world, basically, because I said very few is published on this data. And also, this is such important information for the leadership, for the board, to make them support you in your quality improvement work. So just 2 more comments and we're done with our questions and answers. Unfortunately, we see you're asking more, but please go to our community of practice. We'll definitely take most of your questions and address them there. The link is shared in the chat. And also all the tips, tricks, downloadable materials and templates, including on quality plan and quality program, you will find in our free online training modules. And Natasha will now tell you how to find them. And I say goodbye, Natasha. The floor is yours.
Yeah, thank you. Can you hear me? Can you hear me, Julia?
Yes. Yes. Yes.
Okay, excellent. So thanks. My connection is not stable today and I apologize for that. So I get to answer some questions that were not answered before. That is, will you get a certificate of attendance for today's webinar? Unfortunately, we do not have this practice, and we do not believe that it will be fair to those who could not join and still watch the recording of our webinar to be able to get all the knowledge that was given today. But how you can get a certificate? You can get a certificate by attending a training, an online training that we talked about today a lot, and I'll show you how to find them. So what you do is you go to our World Bank Group Open Learning Campus. You type WBGOLC in your browser, and that takes you to Open Learning Campus. And over there, you can type one of several courses, 9 courses we have available at the moment, and the 10th one will be coming before the end of the year. So those are from the trainings are from IPSG and related issues. I mean, more practical ones, to foundations of quality. This is the one that we covered that we talked about significantly, and incident management, that would be the course number 9. And also we have so when you take them, you have a certificate. The certificate is shown here. You have a certificate provided into your name, and that is a certificate of completion. Now, when we complete today's webinar, when you complete today's webinar and move to looking for those trainings eagerly, then we ask you to do one of the two things. You either complete the survey on exit and let us know what was the most useful, what we could do better. It will take less than 3 minutes of your time. I think just 1 or 2 minutes. There are only 3 or 4 questions. And we would like, if you would like more detailed feedback, please email to us. So you received an invitation, just respond to that invitation and we will be able to receive your email, okay? So that is basically what I wanted to say. Again, this answers some of your questions. How can we see the training that everybody talked about, the quality foundations of quality training, and about the certificate. So you get a certificate for completing the foundations of quality training, and you can get 8 more certificates for completing the other courses. That's it for me for today. And thank you very much for today's webinar, and I hope that this was useful for you. And thank you very much to the presenters. It was amazing to see how we can learn from an experience of someone that is half the world away from us, but still the experience can be shared, can be replicated, and can be discussed in those online webinars, because our webinars are worldwide and we have participants from over 60 countries, usually.
Thanks a lot. And
All right,
bye-bye to
everyone. Thank you so much.
Thank you all. Bye-bye.